বেরিয়ে গেলে আমরা কি করি? We have to change our lifestyle. ফুড খাওয়ার অভ্যাসটাকে চেঞ্জ করতে হবে। আর কার্ডিওলজিস্টরাও বলছে যে অনেকগুলো ড্রাগ রাখে, এই পাতা থেকে ওই পাতা করে নেয়। এবং কোনটার যে কি সাইড এফেক্ট হচ্ছে এইটা পরে আর বোঝা যায় না। এটা খুবই ডিফিকাল্ট। সুতরাং আমরা ভালো থাকার জন্য চেষ্টা করবো যাতে
200 গ্রাম সবজিতে হবে না এটা, হ্যাঁ, কারণ 7 গ্রাম সলিউবল এবং সলিউবল ফাইবার পেতে হলে আমাকে কিন্তু ওই পরিমাণ ভেজিটেবল খেলে এটা আসবে। আমরা কতটুকু খাই কি খাই না। এবং এই ফ্রেশ ফুডের মধ্যে লট অফ অ্যান্টিঅক্সিডেন্ট আছে। দিস আর ভেরি ইম্পর্টেন্ট। দিস রিয়েলি হেল্পস লিভার।
Honorable Director Sir, respected teachers, my dear senior and junior colleagues, beloved intern doctor, Assalamu alaikum and good morning. Welcome you all to today's morning session organized by Department of Radiology and Imaging. Today's topic, liver in distress, the growing concern of fatty liver disease. This session is chaired by Professor Dr. Mastur Rahman, Professor and Head, Department of Radiology and Imaging. Research person, Professor Dr. Chittaranjan Devnath, Professor and Head, Department of Hepatology. Today's speaker, Dr. Mahazabin Islam, Associate Professor, Department of Radiology and Imaging. Now, I request our chairperson and research person, sir, please come to the dais and conduct the rest of the session. Thank you.
And my senior and junior colleagues and beloved viewers. So, Assalamu alaikum and very good morning. And today's topic is liver in distress, the growing concern of liver diseases. So, it is very common disease. Today's speaker is Dr. Madhav Vishnu. I would like to invite Dr. Madhav Vishnu to present her presentation.
Thank you, sir.
Thank you, sir. I would like to deliver my presentation with the permission of the person. Today's topic is liver in distress, the growing concern of fatty liver disease. Introduction. Imagine an organ in our body working tirelessly to detoxify our system, process nutrients, and support our overall health. Now imagine that some organ burdened by an excessive accumulation of fat struggling to perform its duties. This is the reality of fatty liver disease, a condition that often begins silently but can have serious consequences if left unchecked. As radiologists and imaging specialists, we hold a unique lens into the hidden complexities of the human body. Among the most intriguing and concerning conditions we encounter is fatty liver disease, a growing health challenge that often reveals itself silently through our imaging tools before clinical symptoms appear. Fatty liver disease, characterized by an abnormal buildup of fat in the liver, affects millions worldwide. While traditionally linked to alcohol consumption, advancement in imaging have highlighted the rise of non-alcoholic fatty liver disease (NAFLD) has now emerged as one of the most common liver disorders, fueled by lifestyle factors like poor diet, sedentary habits, and rising rate of obesity. Despite its prevalence, fatty liver disease is often overlooked, earning its reputation as a silent condition. But beneath this quiet surface lies the potential for serious complications, including inflammation, scarring, and even liver failure. The good news, fatty liver disease is reversible in its early stage with lifestyle changes and proper management. The role of radiology in identifying and assessing fatty liver disease is pivotal. From early detection with ultrasound and CT scans to advanced quantification through MRI, imaging has become the cornerstone in diagnosing, staging, and monitoring this condition. These tools not only allow us to visualize the extent of liver involvement but also provide valuable insights for clinicians to guide timely interventions. Diffuse hepatic steatosis. It is a common imaging findings and can lead to difficulties assessing the liver appearances, especially when associated with focal fatty sparing. Epidemiology. Diffuse hepatic steatosis is common, affecting approximately 25% of the population. Pathology. Hepatic steatosis due to the abnormal accumulation of lipids, particularly triglycerides within hepatocytes. These are found in both small and large vesicles. Macroscopically, the liver is enlarged, yellow, and greasy. Steatosis can lead to fibrosis and cirrhosis. Pathophysiologic features. Hepatocytes in the central of the lobule near the central vein are tend to accumulate lipid earlier than periphery. In advanced cases, there is diffuse, relatively homogeneous involvement of the entire lobule. Steatosis may progress to steatohepatitis with inflammation, cell injury, or fibrosis accompanying steatosis and cirrhosis. Etiology. Diffuse hepatic steatosis is often idiopathic. However, it may be associated with non-alcoholic fatty liver disease, which is associated with insulin resistance or diabetes mellitus, obesity, dyslipidemia, exogenous steroid intake, drugs like amiodarone, methotrexate, chemotherapy, total parenteral nutrition use, pregnancy, acute fatty liver of pregnancy, metabolic disorders, glycogen storage disease, Wilson disease, radiation, and alcohol abuse. Clinical presentation. Clinical features include fatigue and right upper quadrant pain and hepatomegaly. However, most individuals are asymptomatic. Image-based diagnosis of fatty liver, diagnosis by ultrasound, diagnosis at CT, and diagnosis at MR imaging. Image-based diagnosis of fatty liver usually is straightforward, but fat accumulation may be manifested with unusual structural patterns that mimic neoplastic, inflammatory, or vascular conditions. Diagnosis at ultrasound. Normal liver shows echogenicity of normal liver mildly exceeds that of renal cortex or spleen. Intrahepatic vessels are sharply demarcated. Posterior aspect of the liver and diaphragm is well depicted. Grading of fatty liver by ultrasound. Grade 1 fatty chains diffusely increased hepatic echogenicity, but periportal and diaphragmatic echogenicity is still appreciable. Grade 2 diffusely increased hepatic echogenicity, obscuring periportal echogenicity, but diaphragmatic echogenicity is slightly appreciable, still appreciable. Grade 3 diffusely increased hepatic echogenicity, obscuring periportal as well as diaphragmatic echogenicity. This is the comparison between normal liver and grade 1 fatty liver. In normal fatty liver, periportal echogenicity and diaphragmatic margin is well demarcated. Echogenicity is mildly slightly greater than renal parenchyma, and in case of grade 1 fatty liver, echogenicity is diffusely and mildly increased. Periportal echo is present and diaphragm is also visualized. In case of grade 2 fatty liver, periportal echo is lost, diaphragm is still visible, and mildly or more than mildly increased echogenicity than renal parenchyma, renal cortex. This is another case of grade 2 fatty liver. Diaphragm is still visualized, but periportal echo is lost. This is grade 3 fatty liver, marked increase, diffuse increase of echogenicity of the liver, and periportal echo is lost, and also diaphragm is not well visualized or not visualized. This is another fatty liver, grade 3 fatty liver, diaphragm or distal part of the liver is not visualized. Periportal echo lost in the fatty liver. This is also periportal echo of normal liver and lost in fatty liver. Some picture from our patient. This is 37-year female patient came with a previously diagnosed polylithiasis, and eventually we find severe fatty change in liver. Periportal echo is lost, diffusely increased echogenicity, then renal cortex and diaphragmatic margin is not visualized. This was a 12-year boy diagnosed with moderate fatty change. Liver diaphragmatic margin is faintly visualized and increased echogenicity. Mild fatty change, periportal echo is present, diaphragm is also visible, and echogenicity is mildly increased. Diagnosis at CT scan. Diffuse steatosis reduced liver attenuation. On non-contrast CT, moderate to severe steatosis, at least 30% fat is predicted by relative hypoattenuation, liver attenuation at least 10 Hounsfield unit less than that of spleen, absolute low attenuation, liver attenuation lower than 40 Hounsfield unit. In normal liver, CT scan shows the normal liver has a slightly greater attenuation than the spleen and blood. Intrahepatic vessels are visible as hypoattenuated structures. In fatty liver, attenuation of the liver is at least 10 Hounsfield unit less than that of the spleen, or attenuation of the fatty liver is less than 40 Hounsfield unit. In severe cases, intrahepatic vessels may appear hyperattenuated relative to fat-containing liver tissue. This is a picture CT scan of normal liver. Vessels are showing hypoattenuated than the liver parenchyma, and liver is greater than splenic density. And in case of fatty liver, liver density is only 15 Hounsfield unit and spleen is 40 Hounsfield unit, and vessels are seen as hyperechoic, hyper attenuated than fatty liver, hyperdense. MRI requires both in-phase and out-of-phase imaging to be adequately assessed. Fatty liver appears H1, T1 in hyperintense, T2 mildly hyperintense. In-phase and opposite phase imaging signal dropout on OOP imaging. This is T1 or IP imaging. Liver is hyper than the spleen, but in OOP, the liver signal is dropped than T1 and slightly similar to spleen. Other MRI uses: MR spectroscopy, accurate quantification, non-invasive assessment of hepatic steatosis. MR elastography shows promise as a method for assessing accompanying hepatic fibrosis. Fibroscan. Fibroscan is a technique that exploits the fact that a pathological process alters the elastic properties of the involved tissue. This change in elasticity is detected and imaged using elastography. Using liver stiffness result to find fibrosis growth. 2 to 7 kilopascal is normal liver condition. 7.5 to 10 kilopascal has moderate scarring. 10 to 14 kilopascal has severe scarring. More than 14 kilopascal has cirrhosis. Nuclear medicine, technetium 99 M sulfur colloid uptake is reduced in fatty liver. Reduced hepatic uptake related to the spleen. Focal fatty areas can simulate a hepatic mass. Focal hepatic steatosis. Focal hepatic steatosis, also known as focal hepatosteatosis or focal fatty infiltration, represents small area of liver steatosis. In many cases, the phenomenon is believed to be related to the perfusion difference of the liver tissue. This is a picture of focal fatty change or focal fatty area. This mass-like structure is actually a focal fatty infiltration, and rest of the parenchyma of the liver is normal. And this is CT scan of focal fatty infiltration. This is normal, and this is hypointense part is fatty change. Differential diagnosis of focal fatty change. Differentials considered include hepatic hemangioma, the commonest hyperechoic liver lesion, hepatic abscess, liver neoplasms, primary liver tumor, or hepatic metastasis. Metabolic dysfunction associated steatotic liver disease. Metabolic dysfunction associated steatotic liver disease or MASLD, previously known as non-alcoholic fatty liver disease NAFLD, is a subtype of steatotic liver disease. It occurs when patients have hepatic steatosis and at least one of 5 cardiometabolic risk factors. The deposition of fat may lead to hepatic inflammation, hepatitis, and eventually to cirrhosis. Cluster of risk factors including obesity, raised blood pressure, high blood glucose, abnormal lipids, as well as abdominal obesity. Terminology: in June 2023, the term NAFLD was changed to MASLD to incorporate new thinking and categorization of the steatotic liver disease. The global prevalence of MASLD is increasing and was estimated at 30% of the global population in 2023. It is now the most common chronic liver disease, and the prevalence is projected to increase to over 55% by 2040. Once fatty liver is found, look for the cause. If no cause is found, labeled as NAFLD, non-alcoholic fatty liver disease. This affects 10 to 20% of the population. Those with normal liver enzyme can be managed with reduction in weight and lifestyle modification. Those with persistent elevated liver enzyme are called NASH, non-alcoholic fatty liver disease, which may lead to cirrhosis. Conclusion. In conclusion, fatty liver disease is a rising global health concern strongly linked to obesity, diabetes, and metabolic syndrome. Radiology has become indispensable in addressing this challenge by providing non-invasive, reliable, and accurate tools for the diagnosis, staging, and monitoring of the disease. Imaging modalities such as ultrasound, CT, and MRI play a vital role in assessing hepatic fat content, fibrosis, and disease progression. Among these advanced techniques like elastography offers detailed quantification of the liver fat and stiffness, significantly reducing the need for invasive liver biopsies. One of the key achievements in this field is Fibroscan, a specialized elastography-based tool for assessing liver stiffness and controlled attenuation parameter value. Fibroscan provides a quick, non-invasive method to evaluate liver fibrosis and fat content, making it an invaluable resource in diagnosis and monitoring fatty liver disease. Its accessibility, ease of use, and high diagnostic accuracy make it particularly beneficial in outpatient settings and mass screenings. Looking ahead, the integration of Fibroscan with other imaging modalities along with artificial intelligence and machine learning promises even greater diagnostic precision and efficiency. A multidisciplinary approach that combines radiological insights with clinical expertise is essential for the effective management of fatty liver disease. By advancing image technologies like Fibroscan and fostering collaboration among healthcare professionals, radiology will remain at the forefront of combating this widespread condition, improving patient outcomes, and reducing the burden of liver-related complications. Thank you.